over to Cheryl. Just a bit of housekeeping about who we are as an organisation, a couple of lines of who Benenden are. We are a healthcare provider. We've been supporting and working within civil service organisations such as the UK, the Northern Ireland Civil Service since 1923, and now the support has been extended for us to be able to deliver these bespoke sessions for you today, which hopefully will continue for many more years to come. If colleagues want a bit more information or what resources we have available on Benenden Health, or if you're not already a member and wanting to join, I'll pop some details into the chat pane throughout this session. As I said, the slides and the recording will be available following the session, and Ronan will hopefully put into the chat as to where these can be accessed. So without further ado, Cheryl, the floor is yours. Enjoy the session. As I said, if there is any questions that you want to ask, please use the chat pane, put your hand up, and we'll hopefully pick these up as we go along throughout the session. Cheryl.
Oh, cheers, Matt. Thank you. Morning, everybody. As we've already established, I'm Nithered, Mark's Parker, and somebody's currently doing the coast to coast. So we've already done a full morning session, haven't we? But let's see if we can squeeze in some chat about diabetes whilst we're here. So I'm sure most of you have met me by now. If not, so lovely to meet you all. Thank you for coming to this morning session. My name's Cheryl. I'm a nurse consultant by background. I was in general practice for many, many years, and I would see, diagnose, treat and manage patients exactly the same as a GP, with all the same rights and responsibilities. But this morning, what we're doing is we're going to be chatting about diabetes. If you've got any questions or you just want to pass comment, pop it in the comments box, the chat box at the side. Absolutely fabulous to do so. I'll try and pick the questions up as we're going. If you've got any questions that really you wouldn't feel comfortable popping in an open forum, I'm going to ask Mark to pop his email address in the chat box. Email Mark and I'll get back to you. Usually takes me 24-48 hours, but I always get back to everybody. So diabetes, it's one of these words that's you know what I mean, chatted about an awful lot, but let's see if we can get a little bit of understanding about what causes it, why we get it, what effect it has on us, and how we can manage that. So we know that diabetes is a metabolic disorder, okay, which means it's that the body's inability to produce any or enough insulin, and what happens then is, because we're not producing enough insulin, we get raised level of glucose or sugars within the body. What happens is your pancreas doesn't make insulin, or it doesn't make enough insulin, or actually the insulin that's there isn't working properly. So quite often it's a combination of effects that happens. And insulin is a hormone. It's produced by your pancreas. So your pancreas is sort of like right up underneath the right side of your ribs, and your pancreas produces that insulin. And what the insulin does is it allows the glucose to enter the body. And we get our glucose, which is our energy, from carbohydrates. So yes, you will get it from sugars, but you get the bulk of your glucose from carbohydrates. So we're just going to dip into how diabetes is looked a little bit further. So thank you, Mark. So what we know is that what all types of diabetes have in common is that there is too much sugar in the body, too much glucose in the circulating bloodstream, and not enough insulin, or the insulin isn't working properly. What the glucose does is it gives us our energy, okay? It's when we get it in the body, when we eat anything. So for example, we're going to have a sandwich for us dinner today. Obviously, because we know that it's important to eat our rainbow, we're going to have a lovely salad sandwich, and we're going to have some, you know, carrots or peppers or tomatoes on the side, something of that nature. But what we're going to do with that sandwich is it's in bread. Bread is a carbohydrate. We eat that sandwich, it goes into the body, and the stomach breaks it down through its normal digestive process. And that bread, that carbohydrate, is broken down and converted into glucose. So it's giving us that energy for our bodies to move and to motivate. When we get the glucose level rising within the body, the pancreas realizes that the glucose level is rising and thinks, right, I know that too much glucose is bad for us. I need to do something about it. So a place called the islets of Langerhans generate and release insulin into the blood system, and the insulin opens up those cells. So on the right hand side of the screen, the little key shapes are what's meant to be the insulin. They go and they unlock the cells, and they allow the glucose, the little squares within the infographic, to enter the cells. So we've got lots of lovely energy within our cellular structure, so our bodies can do all the things it needs to do. And that's the normal physiological process of how our bodies use our carbohydrates, convert them to glucose. The pancreas realizes our glucose is going up, secretes some insulin. The insulin unlocks the cells and the glucose goes into the cells. And that's what happens normally. Now, what we know when we have diabetes is that either the insulin isn't enough, so we've not got enough keys to unlock the cells, the insulin keys to unlock the cells, or the keys aren't the right kind, they're not opening the cells, it's not effective, or actually we've just got far too much circulating glucose, we don't have enough insulin. So what happens is that glucose level rises within the blood, and it causes that raised sugar levels, those raised glucose levels. Now, what we know is that there's two predominant types of diabetes. So you've got type 1 diabetes, and that's where your pancreas does not produce any insulin at all, and type 2. And what we're going to do is we're going to discuss that further in the next slide as we move on to the next slide. So type 1 diabetes, this means that your pancreas, your body, is not making any insulin at all. There's no insulin there. So if you imagine that you're going by your normal day and you're eat, and your sugar levels are going up, it can make you very, very unwell, because there is no insulin, there is no keys to unlock those cells to allow the glucose to go in. Most types of type 1 diabetes are diagnosed in young people. So it's usually children and young adults that get diagnosed with type 1 diabetes. It's not preventable, you can't prevent it, but you can treat it once it's been diagnosed. You can have a predisposition to type 1 diabetes, so in your genetics, sometimes you can have a predisposition, but then there is also research saying, is it something to do with the weather, viruses, etc., that is increasing the prevalence of type 1 diabetes? So they're saying there can be some environmental triggers to the disease, albeit that's very unfounded research at the moment. What we know with type 1 diabetes is that it can, if not diagnosed, it can be a killer. So it needs to be diagnosed and it needs to be aggressively managed. You can't play about with type 1 diabetes. You can't think, shall I take my insulin today? Shan't I take my insulin today? It is very, has to be very, very closely managed. And what we often know with type 1 diabetes, because these are young people that get it, young people want to be out and about with their mates. They want to be drinking alcohol, carbohydrate, raise your sugars, can't be good. They want to be going and having that kebab at 3 o'clock in the morning when they're falling out of the nightclubs. They don't want to be checking blood sugar levels. They don't want to be having to inject insulin. They don't want to be monitoring the diet. They want to be the same as their friends. So a lot of young adults with type 1 diabetes can often struggle. And what we find is that it can be a real steep learning curve for a lot of the early diagnosed type 1 diabetics. Whereas type 2 diabetes is quite often, it's what's known as lifestyle in orientation, quite often is type 2 diabetes. And what we mean by lifestyle in orientation is that because we tend to be much more sedentary with our lives, yeah, we're not up and about as much as we were. If we think about our parents, our grandparents, etc., usually their jobs were much more manual, so they were much more active at work. If they wanted to do anything, they usually had to be active to do it. Even something as simple as changing over the TV, you had to get up off your chair and push the button on the telly, didn't you, before you could sit back down. Everything that we do now is around convenience. You know, you want to order food, you pick up your phone and you order food over your phone. You want to change the channel on the TV, you pick up the remote and you press the button. Everything we do is about ease and speed nowadays, so we're not as active. And what we found with our diets is that our diets are far higher in processed foods than they were many years ago. So we know that processed foods have a higher level of sort of like additives in there, higher level of sugars in there, higher level of carbs in there, etc. People aren't eating I call it a raw diet, and what I mean by that is that if you're eating a carrot, you recognize it as a carrot. You buy carrots, you cut them up, you cook them, so you recognize that carrot. It's not something that you pull out of the microwave in a ready meal and you ding. You know, we need to be quite clear that our diets have evolved, and because of that lack of exercise and that evolution in our diet, our sugar levels have been going up and up and up, and we're not jiggling as wiggle enough to keep them down. So the body's having to produce more and more insulin to get those sugars sorted out so that they're at an even keel. So the pancreas becomes tired. It can't keep producing that level of insulin for that really high level of sugars. So our lifestyles are definitely making us much more prone to getting type 2 diabetes. Now, I know that somebody had popped in there, I think, about diabetes being reversed. So the thing with reversing diabetes is, to a certain extent, if you nobody cures themselves of type 2 diabetes, but you can reverse the levels. So you can't cure yourself, but if you dramatically overhaul your diet and your lifestyle, you can reverse your levels. And I think that's what one of Julianne said there, and absolutely brilliant. Yeah, it is that ability to jiggle your wiggle more, look at your diet, make sure you're eating the very best that you can, that can help that come down. And people also might say, well, why do I need to? Why is it important for me? You know, what's the problem of having diabetes? So what we know is, but with this metabolic disorder, is it literally affects us from the tip of his head to the tip of his toes. It's a full body thing, is diabetes. So it affects your eyes, it affects the very tiny blood vessels in your eyes, it affects your heart, it affects your kidneys, it affects your dental, you get increased dental disease, increased stroke, you get nerve damage, urinary function problems, sexual desire problems, impotence problems, nerve damage problems, foot problems. It literally, diabetes affects us from the tops of our head to the tips of our toes. And the reason that it does that is because it's a vascularly led problem. So remember what we said about our, we need the insulin to unlock the cells. All that's going through your blood flow, so it's all vascular fed. And our blood flow goes from the tip of our heads to the tip of our toes. So wherever your blood's going, if your sugar levels are high, it's going to be affected. So we're talking about high sugar levels and things like that. What should your sugar levels actually be? Let's have a little look at that on the next slide. So, sorry, excuse me a second. Done too much chatting already this morning. Could you move the slides on for me, please, Mark? So when we look at our blood sugar levels, what we know is that they differ for everybody. But generally speaking, if you're monitoring your blood sugars at home, you'd use a self-testing kit, okay? And the normal levels are between 4 to 7. Thank you, it's just come up. Thank you, Matt. It's between 4 to 7, okay? And that's before eating. That's on no food in the system whatsoever. So first thing on the morning, you get up, we work from the left-hand side of the screen, you'd finger prick your test, always on the pad of your finger. We usually recommend on the side because you've got more nerve endings on the front pad, so on the side pad of your finger. Take a little bit of blood on a morning with no food in the system. You would need to be between 4 and 7, and that's a rough normal reading that you get. Now, when we eat, it takes very roughly 2 hours for your blood sugar to peak at its maximum level, because don't forget, when we eat, those carbohydrates that we eat get broken down into food, get broken down into glucose. So your glucose, your sugar level is going to rise. And that tends to do it 2 hours postprandially. So if you get up in the morning and you're between 4 and 7 with no food in your tummy, you then had some porridge for your breakfast with some berries or whatever, 2 hours after that, it would rise. And we would expect it to rise, you know, up to about 9 or 10, dependent upon the meal that you'd had after 2 hours. And then again, it would come down. What we do know is that that's what that test there is telling us is what your sugar level is here and now, in the moment. But actually, from a clinician point of view, what we find more helpful is a figure called your HbA1c. So HB for hemoglobin, A1 is the A1c is the sugar molecule that attaches to the hemoglobin cell that's going through your vascular system. And what the HbA1c tells us is what your sugar level is over a 3-month period. So it gives us an average over 3 months. So it's really interesting from a clinician point of view to look at what your average sugars are over that 3-month period, because that's what we would use to diagnose. We wouldn't use the finger prick test necessarily to diagnose diabetes. Now, what we know is if you were a diabetic and you were taking your finger prick test and the sugar level was very low, we would advise that you eat something, and I will go through this later on. If your sugar level was very high, then you may need, if you are on insulin, to inject your insulin levels. And what the middle infographic there is what an insulin pen can look like. And injecting is not like having a blood test. It's not going into a, you know what I mean, a major muscle. It's a really quick and easy process to inject. And the needles are so fine. A lot of diabetic insulin users tell us that they don't have any issues. They don't feel the needles at all. Really, really quick and easy to do. The infographic on the right-hand side is one of the newer ways of keeping an eye on your blood sugar levels. And this is a little monitor that sits underneath the skin. So quite often you might see people with a little bit of a disc on the upper arm that they can scan with their phones, and that tells them their sugar levels. Or they might have one of these little discs here. And the one that's on the infographic there can also deliver insulin. So it will constantly monitor your sugars and then give you the appropriate level of insulin to manage those sugar levels. So things have come on in absolute leaps and bounds in managing diabetes. Insulin historically only used to be associated with type 1 diabetics, But what we do know is that it has benefit for both type 1 and type 2 diabetics. So if you are a type 2 diabetic, you may well find that if you're not able to manage your sugars otherwise, you would be on insulin as well as oral medication. So let's have a look at some of the risk factors for type 2 diabetics on the next slide. So what we know is when quite often when we get people coming through our GP surgeries, there's two different ways within which we quite often diagnose people or spot people with diabetes. Sorry, I'm super thirsty this morning. I do apologise. So what we find is that quite often somebody will come to us and they'll feel very, very tired, or they'll be weeing an awful lot, or they'll be getting recurrent infections, or quite often gents will come in with erectile issues. And that's the sort of like common things that we would see that would make us as clinicians think, is this diabetic? So the other reasons that we might think is a person diabetic is the fact that we might be doing a general health check on them. So we might be looking at your cholesterol, your height, your weight, that type of thing. And that might give us some of those indications. And when we're doing those health checks, one of the things that we're looking for is we're looking at your weight, aren't we? So we would look at your BMI. And actually, if you're overweight, it increases your risk factor of diabetes. If you're sedentary, so remember what we said about we're not moving as much. So if you're sedentary, that again can definitely increase your risk of diabetes. And part of the reason for that is we're not using up the glucose, the energy that we're taking in. So we're taking in far too many calories, creating far too much internal energy and not using it up. So our calorie intake is higher than our calorie output. Sedentary lifestyles, not good. If we're older, it increases our risk factor. So we've got there 40 and above, but actually what we do know is that if you are from certain ethnicities and older, that will increase your risk factor as well. So Southeast Asian origin definitely increases your risk factor for diabetes, as does your age alongside that. If you've got parents or siblings with diabetes, increases your risk factor. If you've had gestational diabetes, so what gestational diabetes is if you develop diabetes while carrying your babies. So while pregnant, if you develop diabetes, that's called gestational diabetes, and increases your risk factor for developing type 2 diabetes in later years. If you have had gestational diabetes, you should be having an annual sugar test and an annual HbA1c every year, just to keep an eye out that you're not developing diabetes. And it's your GP practice who should be organising that for you. The next one that's there is about impaired glucose tolerance or impaired fasting glucose. So what this is it's commonly known as the pre-diabetic markers. So your blood sugar levels are showing us that they're high, but they've not quite tipped over into the diabetic level. So with this one, this is all about that. It's giving you that warning shot that you're moving towards diabetes. So this is about, you know, my sugar levels are rising. I need to do something to prevent some of those complications coming along. And that's about looking at your diet and looking at your exercise. Abnormal blood cholesterol levels, your lipid levels, that's again suggesting that your diet's not ideal, that you're not moving enough. So we need to be looking at that. And again, high blood pressure, again, is another indicator because of the effect that high blood sugar levels have on our vascular walls, our blood vessel walls. It can affect our blood pressure. So again, all these are real common risk factors. And can see that Paul's put in there normal type 2 reading in the morning. So this was on the earlier slide. If you haven't had anything to eat whatsoever, a normal blood sugar reading should be between 4 and 7. If you have had something to eat, your blood sugar level would be higher, especially 2 hours postprandially, post-eating. How would a non-diabetic's blood glucose compare to a diabetic's after a meal? So this is slightly different. It depends upon, I can't give you a definitive on that one. And the reason for it is, it depends on the two individuals because, as we said, they are different for everybody. But what we know is a diabetic's blood glucose level will go much higher because their insulin isn't working. It's not opening those cells to let the glucose go in. So we know that the diabetics' blood sugar levels, type 2 diabetics' blood sugar level, is going to go higher than the non-diabetics because their insulin isn't as effective. But I couldn't give you it'll go 3 points higher or 6 points. It depends on the individuals that you're referring to and where they are within their insulin regulation. So what we would do if we saw anybody for those risk factors of type 2 diabetes, we would definitely do your height, your weight, your blood pressure. We would look and have a chat around those kinds of things. We would then do a blood test, and within your blood test, we would probably do, sorry, I'll come back to that, Paul, bear with me. We would probably do a combination of blood tests for you. We would look at your cholesterol levels, we would look at your kidney function, your liver function, and we would look at the blood test. If you remember me saying about the HbA1c blood test, we would have a look at that HbA1c blood test because that gives us that 3-month average. And it's on that blood test that we would make a diagnosis. If we found that it was in that impaired tolerance or impaired fasting glucose level, if it was within that factor, then what we would do is we would repeat it 3 months down the line before making a diagnosis. So you might find a series of blood tests that you'd need. The reason that we would be doing your kidney function and your liver function is that our kidneys are dramatically affected by our diabetic status, and our liver, if we need to start you on any tablets, our liver is a big metabolizing department, and that again, you know what I mean, we'd need to know the status of your liver before we started you on any tablets, so we'd do it all in one. So a level of 9 in the morning, it depends how late the previous night you ate and what your current health level is. So if you're a diabetic, already a type 2 diabetic, I would try very hard to try and get that down to sort of like more towards the normal 4 to 7 if it's a total fasting figure. If that 9 is when you've had your first brew on a morning with a little bit of milk in there, the milk will convert to carbohydrates, so the 9 might be secondary to that. So it depends on your general health status and, you know, where you are within that. And PCO, polycystic ovaries, yes, that can be a risk factor for developing diabetes. And the challenge with polycystic ovaries is that we struggle to lose weight, etc., with PCO. But one of the treatment options for PCO is a medication called metformin, which is a common medication used to help treat diabetes. So whilst it is a risk factor, what we do know is that some of the treatment options for PCO are also there to help support diabetes. Is there a pump that combines the blood glucose monitoring and insulin in one machine? I believe there is, yes. There definitely was when I was in general practice. So I came out of general practice 4 years ago, and there was definitely one available that the secondary care settings had to do. You know what I mean? Secondary care clinicians, the endocrinologists could issue for you. It couldn't be issued in general practice. So that might be something you'd need to be under the hospital for. So let's have a look at some of the complications as we move on. Iris, oh gosh, that must have been so frustrating for you. Definitely, if you've got diabetes now, hopefully the session will be of help for you so that you'll be able to have a look and see and go through. So really good question, Elaine. I will come back to that one for you. So diabetes complications. Remember what we said is our sugars and insulins are transported through our blood flow system. So literally, you know, tops of heads, tips of toes, everything's going through that big motorway system. And the way that I think of our vascular system, our blood flow system, is the way that I think of a motorway system, a road system. So our arteries are our motorways. They're wide, they're fast flowing, there's no junctions in them, you just keep going. That's what your arteries are. Our veins are our A roads, a little bit windier, couple of stop starts for those traffic lights and junctions. So that's your valves in your veins. So your veins are a little bit windier, a little bit like the A roads, and then your capillaries are like your backcountry B roads, really, really windy. Okay, so your vascular system is vast. It covers every part of your body, whether it be artery, vein, or capillary. So every part of your body can be affected by diabetes. Blindness, so the arteries and the veins that feed the eyes are some of the smallest in the body. So it's you can get diabetic retinopathy, and that can be a common side effect. So if you do have diabetes, your eyes will be monitored on a regular basis to make sure that there isn't any problems with the vascular flow in the eyes causing issues with the retinas. Heart attacks, vascular again, it affects how the veins and the arteries work, opening and closing. Kidney failure, so kidneys are our big filters in our body. They're like sieves, are our filters, and their job is to act as all the waste matter comes in. If you imagine, you know what I mean, a flour sifter, that's what your kidneys should be. So the only things coming out of the flour sifter is waste fluid. You shouldn't be losing any of the goodness. What happens when we get diabetes is that flour sifter turns more into a colander. So you're losing some of the goodness as well as the waste fluid. So our kidneys don't tend to work as well with diabetes because we're losing good proteins as well as, you know what I mean, that excess fluid that we need to lose. Stroke, vascular problem, dental problems, we're more prone to infection with higher sugar levels, so definitely can make an issue. Amputation, that tends to be because the vascular flow isn't good. You also struggle with nerve damage, which is further on there. And what we find with that nerve damage and vascular flow, because you can't feel if you've got a wound, people tend to leave wounds, and wounds generally take much longer to heal in diabetic people. Pregnancy-wise, pregnant ladies tend to have much bigger babies because of that excess circulating glucose, and it increases their risk of earlier delivery and not always successful delivery. So ladies who are diabetic have to be really carefully monitored during their pregnancy. Sexual dysfunction, so the nerves and the blood flow that feeds the penis are some of the smallest in the body, and if they're not working properly, quite often gents can struggle to get an erection or maintain an erection. So again, if somebody comes in with sexual dysfunction, diabetic testing is one of the first things that we do. And then the other complication, which seems a little strange to put insulin injection within complications, and the reason that we put that there is because people who are on insulin and continually injecting, if they're injecting within the same place, you know, it can cause problems with the injection sites and increased infections there. So we've got to be really careful. The only way that we can manage these complications is by keeping that blood sugar level as normal as we possibly can. So let's have a look at some of the questions coming through. So sorry, guys. I know a lady asked around Slimming World. Anything that we do from a dietary point of view is about taking in less calories than we work out. Yeah. So I say this and it sounds really glib, but I know that it's not. I'm a lady who has had, you know, has more cuddle factor than is healthy for her, but I work really hard to be healthy within that. It's much healthier to be a little bit overweight and active than to be of a normal weight and inactive. So anything that we need, that we do from a healthy weight point of view, is about taking in far less calories than the body is using. So if your body is using 2,000 calories a day, if you're wanting to lose weight, you need to be using maybe 16 to 1,800 calories a day. So your body's in a calorie deficit. And the calories that you're using need to be of the best quality that you can. Because if you're limiting your calories, you can't expend them on Kit Kats and Mars bars because they're high calorie content and low nutritional content. So it's about looking at the foods that you have. And this is where we talk about eating your rainbow and jiggling your wiggle. So whether you're doing Slimming World, whether you're doing Weight Watchers, whether you're doing on your phone MyFitnessPal or anything like that, it's about getting in the lower amount of good quality calories to what your body is actually needing. That's how you're going to lose weight. So don't be too worried about, you know, buying Slimming World meals and Weight Watchers, crisps and etc., etc. Look at the calories that you're taking in and get those to be the healthiest calories that you can. So you don't need to be paying your, I don't know how much it is at Slimming World, £5, £10 a week to stand on the step of shame, to have somebody suck their teeth at you and go, ooh, £2 on. All that you need is to use something to help you count your calories. Cheap, cheerful, you know, puts you in control of what's happening there, and it helps. Where the slimming clubs work really well is because you've got that group support. So paying for a slimming club and not staying for group support, you're missing out on the benefit of it. Yeah, because it's healthy eating is not rocket science, but actually the group support is what gets you through. So if the slimming clubs are your thing, brilliant, but it is about, you know what I mean, making it work in the best way. So yeah, and so a lot of people are saying Slimming World does work, it doesn't work. It's how you use it. It's like anything, you know, you can buy 20 diet books, but buying 20 diet books will not lose you £20. The only thing that'll lose you £20 is you eating better and moving more, being in that calorie deficit. So I know that as we move on to the next slide, one of the things that we chatted about was amputations and things. And a lot of people wonder why, as clinicians, we get really het up about diabetics' feet. And we have to be really, really cautious and careful with our feet. Sorry, guys. Because of the lack of nerve sensation that we quite often get, a lot of people with diabetes don't realise that they've got wounds on their foot. So, you know, you're out on a Saturday night in an inappropriate pair of shoes. I think, you know, most of us have done it at some point. It might be new shoes that have caused a blister. It might be too high shoes, too narrow shoes. You get lots of blisters. If you've got diabetes, you might not notice some of those blisters, and you are more prone to getting infection, and that infection takes much, much longer to heal. So it's really important that you look after your feet. Make sure that you check them at least once or twice a week for any broken areas of skin, any athlete's foot, any calluses or anything like that. So definitely have a look at the feet and, you know, keep a good close eye on those. Don't walk about the house or anywhere with nothing on your feet. It increases your risk. Make sure that your toes are cut, toenails are cut properly. Make sure that if you have athlete's foot or anything, it's managed really quickly, because it is a very quick and easy source of infection. We're just going to very, very quickly talk about some of those life impacting effects of diabetes. So on the next slide, we look at something called hypoglycemia. And what hypoglycemia is low blood sugars. Now, this usually occurs to type 1 diabetics, so those that are on insulin totally, who don't make any insulin, so they have to use it. So type 1 diabetics are very at risk of getting hypos. Type 2 diabetics, if you are on insulin, you are more at risk of a hypo, but usually type 2 diabetics who are medication controlled, so tablet controlled, are more at risk of hyperglycemia. And what hypoglycemia is where your blood sugar levels have dropped too low, and this can be life-threatening. Usually the things that we see when we look at hypoglycemic attacks are people often associate it with people being drunk, because you can be irritable, you can be sweaty, you can be shaky, you can be a bit wobbly on your feet, your speech can be a little bit slurred, and you don't quite look with it. And a lot of people sort of like would see a type 1 diabetic who's having a hypoglycemic attack and think, oh, a bit early of the day to be having a little bit of a tipple of something. But if you see somebody like this and it seems out of character for them, do ask them if they're all right. Do ask them if they're diabetic, because as I say, this is a life-impacting condition, is a hypoglycemic attack. And what happens is that the glucose levels fall below a reasonable amount. And what we would say is, if it's under 4, you'll be on the floor. That's the terminology that we use. If it's under 4, you'll be on the floor. So if you take a finger prick test, or you use one of the scans, if somebody's got a patch on their arm or a patch in their tummy, and it tells you that their blood sugar is below 4, they'll probably be having a hypo and will need some sugar to increase their sugar levels back up, because this is life-threatening, this is dangerous. There is certain things as well that can make it more predominant. So alcohol definitely affects your sugar levels, and it can inhibit something called glucogenolysis. And that's where the body is converting the glucose appropriately, so it can affect that. So definitely if somebody's having alcohol and they're diabetic, it can affect their sugar levels. If they've got any kind of infection, so if they've sepsis, that can affect how their body's managing their sugars. If their kidneys or the liver aren't working properly, or obviously if they're not eating well, if they're malnourished. So if you imagine a diabetic on insulin who has diarrhea and vomiting, they could be at high risk of a hypo, because one, the food, they're not getting enough food in, and the food isn't being metabolized enough. So their body isn't getting the carbohydrates to create the glucose, so it's going to drop their sugar levels dramatically. Definitely, if you see anybody having a hypoglycemic attack, if they're able to speak with you, if they're able to chat and okay from that point of view, give them something glucose in orientation. So jelly babies, really good sugar content, dextrose tablets, really good sugar content, Mars bar, good sugar content. But what these will do is they will spike their sugars quickly, and their sugars will drop very quickly because there's no sugar there to sustain. So you want in a long, once they've had those and their sugars are coming back up, get a long acting carbohydrate in there, so something, some toast, a sandwich, some pasta, something that will bring that long sustained carbohydrate levels up. If they're not able to speak to you, that would maybe infer that they're not going to be very good at chewing and swallowing. So if you've got glucose solution, you can rub that on the gums. Some diabetics on insulin do hold that with them. You can use that. Otherwise, make sure you get an ambulance, because this is not something you want to be messing about with. You would need some medical assistance with this one. When we look at hyperglycemia on the next slide, this is where the sugar levels are dramatically high and staying high. And this is quite often the thing that we get to see when we're diagnosing somebody. So being really thirsty, needing to wee an awful lot, skin conditions, getting infections. These are the things that we quite often see. And this, whilst it has long-term implications, it definitely doesn't have some of those short-term implications that hypoglycemia has. So what we would say from a hyperglycemia point of view is have a chat with your diabetic clinician. Are you on the right medication? Do you need to be on medication? Does the dosage need altering? Because we need to bring those sugar levels down to prevent some of those widespread complications. If you know yourself that your diet and lifestyle isn't maybe on point, then what can you do to improve on that? And this does not have to be dramatic, yeah? If you can do the dramatic changes, fabulous, but actually some small incremental changes will make a difference. Rather than taking the lift, take the stairs, you know, while the kettle's boiling. You know my mottos: match on the spot. While you're cooking tea, do the kitchen disco. When you've finished work, go for a walk around the block. On your lunchtime, rather than, you know, sitting at your desk and having a sandwich, walk to the shop, get the sandwich and walk back. Do something to get the body moving and look at the diet. Don't expect to eat like a, you know what I mean, a saint every day, but make sure that when you have a treat, it's the healthiest form of treat and you combine it with movement and exercise. So this is about quality of life to ensure quantity of life. So your quality is about the decisions you make in the here and now will affect the quantity of your life moving forward. So definitely there's lots and lots that we can do. So if you've got type 2 diabetes, what can you do to help and support that? So as we move on to the next slide, we look that type 2 diabetes, we know it's a serious medical condition. We know that quite often it requires anti-diabetic medication or insulin to keep those blood sugar levels under control. But what we do know is we can prevent it by jiggling as wiggle, eating as rainbow, being as sensible as possible at the preemptive part. But actually, if we do get it, what we need to do is we need to be really active within that. And this is literally about doing all those things that we've already talked about. So usually what we find is type 2 diabetics have more cuddle factor, and usually we find that the cuddle factor that they have tends to be around their middle, which isn't good for us because this is our it's within our visceral fat, so it's the fat covering our organs, so it's not good. So you need to lose weight. Losing weight can be a challenge, and it's not about losing half a stone in a week. Anything that you do from that point of view isn't good for us. Yeah. What we need to do is we need to make small incremental changes that might lose us half a pound or a pound a week. And the reason that that is better is because it usually infers that you're instilling a habit into the system that you can maintain, rather than, you know what I mean, like, I'm going to go on a 48-hour fast and that'll lose me 4 pounds. It may well do, but that doesn't mean to say it's healthy or sustainable. We need to be healthy and sustainable, and the way that we do that is we eat healthy. So we look at eating our rainbow, and by that what I mean is how much colour and variety have you got in your diet. Have a look at what you've got for your lunch today. How beige is it? Is it really beige? Have you got any fruit or vegetables in that lunch? And theoretically, half of your meal should be fruit and veg. quarter of it should be protein and a quarter of it should be carbohydrates. So have a look at the foods that you're eating. Each thing that you eat is half of that fruit or veg, is a quarter of it a protein source, is a quarter of it a carbohydrate source. Have a look, that's a really quick and easy indicator. And then the jiggle you wiggle, the be more active, and this is about whatever floats your boat. This is not about dragging yourself to the gym if you hate the gym with a passion. Do what works for you. If for you it's about getting out in the garden, then make sure that you're gardening 2 or 3 times a week. If you've done your garden to death, can you do a neighbour's garden? I'm sure, you know, you'd have family, friends who would love you to help in their garden. If for you it's walking, doing the coast to coast, as we were saying about your colleague earlier, you know, whatever it is that you enjoy doing, if it's yoga, if it's going to the gym, if it's lifting weights, if it's getting out on a bike, if it's playing walking football, if it's playing wheelchair rugby, whatever works for you, please, 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 just jiggle your wiggle at every opportunity for me. And when we look at managing diabetes, it's exactly the same. It's not rocket science. It's about eating your rainbow and jiggling your wiggle, but it's also having that connection with your healthcare professional. So that might be your diabetic specialist nurse, it might be your GP, it might be your endocrine department at the hospital, and working with them and looking at how best to manage. Can you manage it with diet and exercise? Do your sugar levels mean that you need some medication, and which medication is best for you? And when you know that, make sure you take the medication. Otherwise, it's sitting in your bathroom cabinet's not going to do you any good. Take your medication as prescribed. Some medications can take a good few weeks to get in the system. Some medications can have side effects to start off with, but those will settle off and get better as you go along. So have a look and work with your healthcare professional to see what can help. Nearly there on time, guys. So as we move on to the last slide, it is really about any questions. Now, I know that I've been answering some as